Hi, welcome to In a Heartbeat. My guest today is Dr. A.Newman, surgical oncologist, professor of surgery, and director of the Breast Cancer Center for the University of Michigan in Ann Arbor. Before I get started, I'd like to give you a little bit of background about Dr. Newman. Dr. Newman serves as program director for the Breast Fellowship. Dr. Newman holds a master's degree in public health from Harvard University, and she also obtained her undergraduate education at Harvard University with a major in chemistry. She attended medical school and completed her general surgery residency training at the State University of New York Health Science Center in Brooklyn. Dr. Newman was recruited to remain at downstate following completion of her postgraduate training and served as assistant professor of surgery with the program for several years. She completed a fellowship in surgery oncology at MD Anderson Cancer Center in Houston, Texas. Dr. Newman's primary research has focused on ethnicity-related variation in breast cancer risk and outcome, the evaluation and management of high-risk patients, broadened application of neoadjuvant chemotherapy, and special surgical techniques such as skin-sparing mastectomy and lymphatic mapping, sentinel lymph node biopsy. A bit much, right? She's going to explain all of that as when I introduce her. Her extensive research related to disparities in breast cancer risk and outcome have been published in numerous peer-reviewed medical journals and was featured in CNN's documentary, Black in America 2. She maintains a very active community service record and currently serves as Chief National Medical Advisor for the Sisters Network, Inc., a national African American breast cancer survivor support organization. She currently oversees an international breast cancer research and training program involving the University of Michigan, the Henry Ford Health System in Detroit, Michigan, the Komfo Anoki Teaching Hospital in Kumasi, Ghana, and the Corley Bu Teaching Hospital in Accra, Ghana. This teaching hospital in Kumasi, Ghana, and the Corley Buer Teaching Hospital program has focused in the study of triple-negative breast cancer in women with African ancestry. Her work has been acknowledged via several awards, such as the 2012 Triple-Negative Breast Cancer Foundation Hero Award, 2012 National Medical Association Women in Medicine Award, and she was named one of 10 Michiganders of the Year for 2011 by the Detroit News. She serves and holds leadership positions in prominent oncology, academic, and advocacy organizations, and has written many articles and journals. Please join me in welcoming Dr. A.Newman. Thank you.
Oh,
I wanted to get all that
Joan.
in, and it's like, I just, as I was talking, I'm just getting chills. Seriously, I'm thinking, my goodness, what a roadmap. And for those of us and our young people out there to follow, it is just awesome. And I thank you so much for coming down for Ann Arbor to be on the show.
Oh, thank you
In
so
a Heartbeat
much,
is just
Joan.
here. It's been around, and we're just so glad to have you.
Oh, and I am tremendously honored to be here.
Because we all have busy schedules, and I'm going, I'm getting Dr. A.Newman on this show. So I'm just it is really an honor.
Thank you for inviting me.
There are different oncologists do different things. There's a hematology oncologist. There's the oncologist that surgical oncologist, which is what you do. You're not involved in the treatment setup of that, right? Of the breast cancer. You're more into the triple negative. That's what we're going to talk about. Am I on the right road
Well,
there?
you're right that cancer management has become extremely specialized, and one of the wonderful advances in breast cancer outcome is actually that we have an entire community of breast cancer specialists. But those specialists represent different components of the treatments that are necessary for breast cancer. So we have surgical breast oncologists like myself. I'm trained in surgical management of a variety of cancers, but now my career focuses on breast cancer patients. We also have medical breast oncologists who deliver the treatments such as chemotherapy to breast cancer patients. We have radiation specialists who also focus on radiation treatments for breast cancer, just as we have radiologists and pathologists who focus on their aspect of care in breast cancer patients. And so all of us work together as a team to manage the patient with breast cancer. And this is what we call multidisciplinary management of breast cancer. Because we have these teams of doctors dedicated to the care of this disease, we've made tremendous advances in improving the outcome from breast cancer patients, because we know how to bring all of these forces in healthcare, in medicine, all of these tools together to target this one disease. And it's been a very successful endeavor.
So it's like a comprehensive. It's everybody has a part. Once you're
Correct.
diagnosed, the team gets together on the best treatment method.
Exactly correct. It is a team approach,
Right.
and we try to constantly make it clear to patients that it is a team approach, and we want to harness all of our services. We want to bring together all of the best treatments for breast cancer to result in the optimum, the best outcome.
Right. Triple negative breast cancer. Help us to understand and kind of walk us through that. The people that are more at risk, the treatment, the complications, the difficulty of treating,
Absolutely.
the outcomes,
Yeah.
and what's new on the horizon there.
Oh, I'd love to. It has indeed been very exciting on the horizon of breast cancer to see that we are learning a lot more about the heterogeneity, the diversity of breast cancer. Breast cancer is not just one disease. It's actually comprised of a whole spectrum, of an entire collection of different subsets, different subtypes of the disease. One way to distinguish, to differentiate these different types of breast cancer is by looking at specific markers for the cancer when we have biopsy material from a breast cancer. A biopsy involves removing some small piece of tissue from a breast tumor, a breast cancerous growth, and looking at that tissue under the microscope. We can apply special stains, special dyes to that biopsy material to characterize the cancer. The most common features that characterize breast cancer are related to three specific markers. Those three markers are the estrogen receptor, the progesterone receptor, and a third marker called HER2/neu. And these markers are very important in guiding our treatments for the breast cancer. We have exciting treatments that target, that focus on the estrogen receptor and on the progesterone receptor, and so they're very effective at killing the cancer cells that are positive for those two markers. And we have very effective treatments that target or focus on the breast cancers that express or that are positive for that third marker called HER2/neu. So it's wonderful that we have learned how to specifically target, specifically hone in on certain patterns of breast cancer and therefore be more effective in treating them. There are some breast cancers, however, that are negative for all three of those markers, and this is what we call the triple negative breast cancer. Now, for patients with triple negative breast cancer, we are still frequently effective at treating these cancers successfully, but they are more difficult to treat. The triple-negative breast cancers will still, just as with the non-triple-negative breast cancers, require surgery in most ladies to get rid of the cancerous growth in the breast, and usually to check the lymph nodes of the underarm area. Many of these cancers will receive radiation treatments, especially if the woman has had a lumpectomy. But for women who have triple-negative breast cancers, if we are worried that there might be microscopic amounts of the cancer hiding in other parts of her body, such as her liver, lungs, bones, those women will usually require chemotherapy because we don't have any of the targeted therapies to treat these cancers. And unfortunately, the triple-negative breast cancers are more likely to be hiding in other parts of the woman's body. And so the triple-negative breast cancers will more often not only require surgical management, but they are more likely to require chemotherapy. And because of the chemotherapy side effects, it is one of the more feared aspects of breast cancer treatment. But I do want to emphasize that chemotherapy will be very effective. It will work at eliminating, at treating the triple-negative breast cancers. So I don't want women in the audience who may have a triple-negative breast cancer to think that it means that their disease is untreatable. It absolutely is treatable. But unfortunately, we do have to be more aggressive when we treat the triple-negative breast cancers.
So, do you find that when you see these type patients with the triple negative, are they the stages? Are they beyond late stage?
Not always.
Not,
and I'm so glad you bring that point up, because while it is true that we worry more about the triple-negative breast cancers being biologically more aggressive cancers, if you catch it early, you are still more likely to have a good outcome and to successfully treat the cancer. And so for women who are more likely to get a triple-negative breast cancer, breast health awareness is that much more important. And so getting mammograms on a regular basis is very important. Knowing your family history so that you know whether or not you have hereditary predisposition for breast cancer, that is more important. Seeing your doctor for regular clinical breast examination, all of these things are very, very valuable, I would say especially for the women who are at risk for getting a triple-negative breast cancer. And we do have some features that predict an increased likelihood of getting a triple-negative breast cancer. Women who have hereditary inherited susceptibility for breast cancer, women who have many relatives with breast or ovarian cancer, these women are more likely to get triple-negative breast cancer. African American women are more likely to get triple-negative breast cancer. And so in general, among all women in the United States diagnosed with breast cancer, it's really a small fraction that have the triple-negative breast cancers, only about 15%. But if you look at Black women, we get triple-negative breast cancers twice as commonly. Wow. And so among African American women with breast cancer, 30% of them are triple-negative.
Really?
Yeah. And this is one of the features that accounts for the higher death rates from breast cancer that we see in the African American community. We have a greater likelihood of getting these biologically more aggressive cancers. So we need to catch them early. If you catch them early, you are indeed more likely to treat them successfully and effectively.
So if I have a family history and I'm 25 and my mother and my aunt, what should I do? Should I start like really doing my breast exams? Do you recommend I get my mammograms or just sort of be monitored and make sure my physician know, or, you know, you're in your childbearing age and you probably don't go to the doctor. Your gynecologist is everything when you're in your childbearing age. You know, your internist is not as usually your gynecologist. You know, I'm on the other end of the spectrum.
Right.
My internist is...
Yeah. You hit on all the key points just then. Everything you said is appropriate. For the young woman or a woman of any age with a strong family history of cancer, and when we're talking about hereditary predisposition for breast cancer, in general, the cancers in the families that we are looking at would be other breast cancers, ovarian cancer, men in the family with breast cancer. These types of pictures do point towards families that have some inherited issue, something that they're passing along the generations, predisposing them to cancers. Some of these families will have a higher frequency of melanoma or certain skin cancers as well. There are a whole host of inherited syndromes that we have identified which can predispose people in that family to breast cancer.
Right.
And these families tend to get breast cancer at younger ages. So in the United States, the average age at breast cancer diagnosis is going to be in the late 50s, close to 60. Families with inherited predisposition are more likely to get breast cancer in their 30s, 40s, even in their 20s. The rule of thumb that we use in terms of mammographic screening for women in these families is that they should start getting their mammograms at 5 to 10 years younger than the youngest age at breast cancer diagnosis in that family. So for the general population, we recommend starting mammographic screening at age 40. If you have a strong family history and you have a sister or your mother diagnosed with breast cancer at age 35, you might want to start getting your mammogram at age 25 or 30. We can also do additional breast imaging studies to evaluate women with inherited predisposition for breast cancer. One such exam would be a study called breast MRI, or breast magnetic resonance imaging. And this is a specialized study of the breast that can be used in conjunction with mammograms for picking up breast cancer in women who have inherited susceptibility. But these studies don't replace the mammograms. The mammograms are still necessary.
Okay.
They're done as a supplement.
Okay.
So there are a lot of things that a woman can do to protect herself against breast cancer, even if she has a strong family history.
You know, about a couple of years ago, we were experiencing, it was kind of a mixed message that was given out for women. You don't have to get your mammograms every year, and remember that, and we were just all kind of confused, and we were all calling our docs and saying, what should we do, and what was your thought on that? How did that sort of it was such a mixed message. I mean, you know, it was the preventative task and I don't know if the American Cancer, they were still,
Yeah, you're right. It created tremendous confusion. That's the bottom line. And there have been some controversies related to age at which a woman should initiate mammographic screening and the frequency of that mammographic screening. Those debates have been going on for several decades. What we came down to as an oncology, as a cancer treating community in general, was the recommendation that women in the United States, in Western cultures, should start their mammographic screening at age 40 and should continue them yearly thereafter. The confusion that you very appropriately bring out is related to a publication that was issued by the United States Preventive Services Task Force in November of 2009, where they reevaluated some of the historic research that had been conducted regarding mammography screening, and they came out with a recommendation that women start delaying initiation of mammograms until they reach age 50, and that women continue them every other year thereafter. So the confusion was not over whether or not mammograms should be done, it was over the age at which women should start the mammograms. The American Cancer Society, the American College of Surgeons, most of our prominent academic advocacy and cancer treating organizations have continued to come out in favor of women starting their mammograms at age 40 and continuing them yearly thereafter. The question is over whether or not mammograms save enough lives for women in their 40s to justify doing them at that age. But mammograms absolutely work for women in their 40s. But breast cancer is less common among women in their 40s. And so this is where there is a debate over the efficiency of mammographic screening for women in those younger ages. But I and my colleagues with the American Cancer Society continue to recommend that you start mammograms at age 40. And mammographic screening is only relevant to women who don't have any problems in their breast. We're talking about women who do not have any lumps that they can feel or any new abnormalities on their breast exam. For those women, mammographic screening should be continued as a way of detecting the hidden breast cancer, the cancer that is not large enough to form a lump or any abnormality in the breast exam. Women who get a new lump or some change in their breast exam, such as inflammation in the skin, a bloody nipple discharge, but a new lump is the biggest concern. Those symptoms should drive an impulse to see your doctor right away and get that abnormality evaluated. I don't care if you just had a normal mammogram a week ago. If you have a new lump, see your doctor. And if you have a change on your breast exam, see your doctor regardless of your age.
Right. I thought it was interesting. We recently did got our HEDIS scores back and when we looked at the mammographies, we saw a decrease this year. And I don't know if that's related to, the confusion or the change in the Affordable Care Act and all the other things that's going on. And as we, transition to electronic medical records, I don't know where the count or the methodology that we had to use to collect the data. And I think I may speak for many plans. I mean, it was really like we went down in that, and it just really bothered me. And I sort of talked to you about that when we were off, before we got on air, that I'm hoping that is not a sign that we've gotten complacent. And that the new generation of women, or that we're not listening, that we're just, following our instincts and not really doing the self-breast exams. You still recommend that, don't you, doctor, that we do over and beyond because for women that have dense breasts, I mean, I think I always feel a lump.
Yeah.
I do.
You're amazing. You have a knack for picking out all the key points for discussion. And in terms of your initial comment about the frequency of mammographic screening that we're seeing in American women, unfortunately that has been problematic recently, and for all of the reasons that you cited. The confusion that came out of the controversy from the screening recommendation task force, the recession, and simply the fact that a lot more Americans lost their job and lost health insurance. That resulted in women not being able to comply with mammographic screening and not being able to take care of themselves. All of those things played a role. And we, as an oncology community, want to keep getting out the message to women that mammographic screening and breast health awareness is essential. Breast cancer is unfortunately way too common in our community, and it's growing in incidence around the world. Historically, breast cancer incidence rates are higher in industrialized countries such as the United States, Canada, Europe, England. Breast cancer is rising in incidence in other parts of the world as well. In the continent of Africa, in Asian populations, breast cancer incidence rates are rising because of lifestyle to a great extent. But in countries that can afford mammographic screening, it is life-saving, and it very clearly reduces breast cancer death rates because we're more likely to pick up those cancers at early stages. So breast health awareness is critical. Again, for women who have no symptoms, we stress start your mammograms at age 40 and continue them yearly. If you have a new breast lump, see your doctor right away. If you have a strong family history, consider genetic counseling to find out whether or not you should be tested for one of the mutations, one of the inherited genetic abnormalities that can put you at risk for breast cancer.
I want to talk, we've got a few minutes left, the BRCA analysis. From a health insurance perspective, I continue to get the request across my desk, and the medical director and I discussed this. It seems to be that now that the Affordable Care Act, I'm getting more, and the recommendations that we do it, and when should a woman get the BRCA analysis for the genetic testing? Is it a good? It is a tool that is being used to help in the treatment. Does it help in the triple negative?
That's a good point, and there are the mixed issues here. I'm glad you brought up the Affordable Care Act because, fortunately for all of us, there is a mandate through presidential proclamation that as healthcare reform rolls out, that we continue to have coverage for screening mammograms for women starting at age 40. And the Affordable Care Act is also taking into account the ability to cover genetic counseling where it's appropriate. Now, genetic testing involves actually getting some material from a patient that will allow us to extract DNA and check that DNA for whether or not somebody has an inherited predisposition for certain cancers. We can do that by getting saliva specimens where DNA can be extracted, or it can be done through a blood test. But there are limitations as to what we can learn from those different tests. We only know about some of the inherited mutations that predispose for breast cancer. We don't know about all of them. So there will be some families where breast cancer, ovarian cancer is rampant, but the testing for BRCA1 or BRCA2, for example, the most common genes that can have mutations predisposing to breast cancer, where those tests will be completely negative for a mutation. So a woman shouldn't just go out and request that she have genetic testing done. She really needs to have the counseling so that she understands the significance of the test.
And then produce the family history.
Yes.
Make sure that the family history meets the criteria for the test, not because I think I want to get it. I mean,
Very important point.
You know, it is so many questions that I want to ask, and I just, I hope the show enlightened you on breast cancer. And again, I want to thank Dr. Lisa Newman for taking the time out of her busy schedule to come on In a Heartbeat to share the information with us today. I thank you for listening. I thank you for joining us on In a Heartbeat. Have a good day. Thank you very much, Dr.
Thank you, Joan. Thank you very much.